everyone. I'm Megan with Array. On the iPads in front of you, please sign in. And please sign in with an active email and then take the post-test. Once you've completed the post-test, or the pre-test, sorry, there will be slides shown, and on the top menu, there's going to be your course guide, or if you're joining us virtually, that's going to be the booklet. And then there's also going to be a claim credit in which you can scan the QR code with your phone, and then you can claim credit for this. On the bottom, there are engagement buttons. You can ask a question, which will be sent to the moderators. We also have notes and saved slides. On the saved slides and the notes, that will be sent to the email that you registered with, so please do an email that you actively use. If you guys have any trouble, please come to us in the back tech table and ask us questions. Otherwise, if you are online, on the top right corner, there is a place for you to ask us questions, and we would love to get back to you. Thank you.
Well, welcome everyone. Thanks for coming and joining us this evening. So we are here to talk about the nurse's vital role in supporting patients through CLL therapy. So this program is supported by BeiGene, Janssen, Johnson & Johnson, and Lilly. So thanks to all of them for supporting this program. You've got, I'm not going to go through all these, accreditation slides, but you just heard about the Q&A on the iPad, so please shout out your questions on the iPad, and then I think we had microphones there too at the end if you want to come up and ask questions at the microphone. So I'm Amy Goodrich. I'm a nurse practitioner at Johns Hopkins in Baltimore, Maryland, and I am going to Nikki.
I'm Nikki Burkett. I'm a nurse at Banner, sorry, is it too loud? At Banner University of Arizona Cancer Center in beautiful sunny Tucson, Arizona, where we're 86 degrees today. And I previously worked as the oral anti-neoplastics nurse navigator. Try that, yep. We're going to talk about that when we get to my part.
Great. And I'm Matt Davids. I direct the clinical research program in lymphoma at Dana-Farber, and I'm an associate professor of medicine at Harvard Medical School in Boston. And you had lots of choices of places to go tonight, but you came to the right room. CLL is very exciting, so you're going to learn a lot, I hope, and we'll have a great discussion.
Nice.
Great, thank you. And so we are going to talk about clinical trials, real world evidence. We're going to talk about targeted therapies. And so our first learning objective, we are going to talk about patient and disease-specific variables that impact treatment selections. And I will give it over to Dr. Davids.
Thanks, Amy. All right, so let's start with some definitions, etiology, pathophysiology, and risk factors. So chronic lymphocytic leukemia, CLL, is the most common type of leukemia in adults in the US, about 25% of all leukemias. But that being said, leukemia is a pretty rare disease, so it's rare compared to other forms of cancer. One of the things is that because CLL patients often live for a very long time, the prevalence of CLL is pretty high. It's estimated that there's over 200,000 people alive in the United States right now with CLL. It tends to be a disease of older folks, so the average age at diagnosis is around 70, and we very rarely see this under age 40, although occasionally we do. In terms of where this disease comes from, it's an outgrowth of lymphocytes that are normally there to fight infections. They look morphologically mature under a microscope. From an immunologic perspective, they're less mature. They acquire these genetic changes that cause them to kind of just gradually accumulate in the body over time. And because they're less mature, this has a significant impact on the immune system, and that's why patients with CLL often have high levels of infections and other complications, even if they're not on treatment. So historically, we think of this as an incurable disease with standard therapies, and there are a variety of different risk scores and staging systems that have been developed over the years. I'd like to show these statistics here, not so much because they're accurate today, but because they're kind of a reflection of what we used to have to deal with in the past. And even when I started in this field about 15 years ago, these numbers were pretty accurate. So historically, 5-year survival could be only about 20% in patients who have very high-risk genetic markers. Although even in the chemotherapy era, there were some patients with low genetic risk who could do very well, so survival more than 90% at 5 years. So a lot of variation in this disease. So for folks like me who specialize in this area, it keeps things interesting because every patient really is very different. So the reason, or the way that we can tell that the CLL cells are CLL cells and not normal B cells is a marker called CD5. It's a protein marker that's supposed to be on the surface of T lymphocytes, but CLL cells come from B lymphocytes. So when we see that CD5 T cell marker on a B cell, we know it's not supposed to be there. And it can be in the blood, the bone marrow, or lymph nodes or spleen. And we can make that diagnosis, as we'll see, I think, in a couple slides, through a test called flow cytometry. In terms of the pathways that drive CLL, there's kind of two main areas. So one is called the B cell receptor signaling pathway, and this is really what drives the CLL cell to grow and to survive. And then there's a second pathway called BCL2 or B cell lymphoma 2, which allows the cells to extend their survival beyond a normal B cell. And so these are some of the key genetic markers that we test, the biomarkers that can predict when patients might need treatment, what the treatment outcomes are, and ultimately, in some cases, what the survival of the patient will be. So the markers include IGHV mutational status. This stands for immunoglobulin heavy chain variable region. Bit of a complex term, but the way I think of this marker is that when a normal B lymphocyte is born, it's got a certain DNA sequence that it has at birth. And in normal physiology, it's actually quite normal for a B cell to be exposed to different viruses and bacteria over the years, and it can actually mutate its DNA to get better at fighting the particular bacteria and viruses that it's encountered in its lifetime. And so if you sequence the IGHV and it's unmutated, that means it's a B cell that was just kind of recently born. But if it's had a chance to mutate its DNA over time, we call that mutated IGHV. And it turns out that this makes a big difference in terms of the behavior of the CLL cells. Those unmutated cells tend to be young and frisky, and they grow and cause problems. The old guys, the mutated IGHV, often, not always, but often are kind of slow moving, not causing much trouble, and those are the patients who often can be observed for a very long time. FISH testing, or fluorescence in situ hybridization, looks at the chromosomes inside the CLL cells. So there should be 23 pairs of chromosomes, 23 from mom, 23 from dad. And then when we look under the microscope with these special fluorescent probes, sometimes we see a little bit of a chromosome that's missing. That's a deletion, or maybe an extra one, like a trisomy. And so a classic one is the high-risk abnormality deletion 17p. When we see that, we know that the CLL is likely to behave much more aggressively, particularly if when we look by a different technique called karyotype, we see complexity, meaning multiple different cytogenetic abnormalities. Some definitions 3 or more, some definitions are 5 or more, but basically, the more abnormalities you see in chromosomes, the worse the cells are likely to behave. And that's particularly true when this gene TP53 is disrupted. So many years ago now, about a decade or so ago, people realized that if TP53 was mutated, those were aggressive patients. And it turns out that this gene is located on chromosome 17, exactly where that deletion is. So whether it's deleted or mutated, it's bad. And so these are things that we can test for at diagnosis, and it gives us a window into the biology of the disease. So a little more biology before we get into the clinical presentation. This is from an old review article that I had put together about 12 years ago now, but it really, I think, sets the stage for a lot of the different treatments that we'll discuss in the clinical part. So the big blob in the middle there is the CLL cell, and the stromal microenvironment is a variety of different cells that support the CLL cell and allow it to survive and even to grow. And these stromal cells are often in the lymph nodes and the bone marrow. And you can see there's T cells and bone marrow stromal cells. Of particular interest to this group is the NLC, which is actually the nurse-like cell. And that is named that way because it really does take care of the CLL cell, allows it to survive. So in this disease, of course, that's a bad thing. But so this is what's happening in the lymph nodes and the bone marrow. These cells are allowing the CLL cells to grow and survive. When they come out into the blood, they're not very happy, and they can actually die off if the CLL cells are in the blood. So it's kind of this constant circulation of cells into the blood. They're not so happy. They come back to the lymph nodes, bone marrow, they get rejuvenated, and then they go back out into the blood. And so now about 15 years ago, one of the really key insights was kind of interrupting that cycle of the cells going into the lymph nodes and the bone marrow. And this was accomplished by understanding more about the B cell receptor signaling pathway, or BCR. And it turns out that this is a pathway that's not only important for the survival of the CLL cell, but also to anchor it in the lymph node and the bone marrow. And so a variety of different drugs have now been developed to target the key pathway of B cell receptor signaling. And the two key targets are BTK, which stands for Bruton tyrosine kinase, and PI3K, which is another good target. And there, you can see there's 6 drugs that are FDA approved for CLL targeting these two nodes. And it turns out actually that these drugs don't necessarily kill the CLL cell very quickly, which initially was a little bit surprising to us because that's usually what chemotherapy does. It kills cancer cells. So it seems like actually the biggest effect of these drugs is it moves them out of the lymph nodes and the bone marrow and into the blood where they're not very happy and they can die off eventually. So that type of approach, as we'll see, is given as a continuous therapy because you need to continue to get these cells out of the lymph nodes into the blood so they die off. And then there's a very different approach that's been developed over the last several years, which is targeting BCL2 with a drug called venetoclax. BCL2 is in the mitochondria of the cell, which is the powerhouse of the cell. So it's quite different from the B cell receptor idea. Here, you're actually just shutting off the lights in the factory. You're killing the cell very quickly with venetoclax. So it's a very complementary mechanism of action compared to the B cell receptor pathway inhibitors. Then from an immune-based perspective, we use CD20 antibodies in this disease, historically rituximab, but more recently a more potent antibody, obinutuzumab. And then just to highlight that we just recently had the first approval for a CAR T-cell product in CLL, Lysocell, which was just FDA approved last month, and this targets CD19. Okay, so with all of those sort of building blocks, let's talk now a little bit more about the clinical presentation. So the most common presentation that we typically see at diagnosis is actually no symptoms at all. It's just the patient had an elevated white blood cell count, their primary care doctor either checked flow cytometry or sent them to a hematologist who checked flow cytometry and made the diagnosis of CLL. But it is true that some patients still do present with the B symptoms, whether it's severe fatigue, drenching night sweats, unintentional weight loss, or fever without infection. Fatigue's always a tricky one, of course, because everyone has fatigue. So that's not often due to the CLL when it's early stage, but certainly can be related to CLL as patients continue to live with the disease. So as I said, the most common presentation is asymptomatic. In later stages, you can see liver and spleen enlargement, which can cause early satiety. And of course, you can see lymphadenopathy, which is probably the second most common presentation after asymptomatic. And then as I alluded to earlier, recurrent infections can really be a problem for patients due to the immunologically immature lymphocytes and the resulting hypogammaglobulinemia. The table on the right highlights some of the differences between acute leukemia and chronic leukemia. I often say to patients, it's unfortunate that we need to use the same term, leukemia, for both types of diseases because they're so different, as you see in the table here. Obviously, acute leukemia is often a life-threatening emergency requiring immediate chemotherapy, and so often when patients hear about the diagnosis of CLL, that's kind of what they think of. But as you see from the table here, usually this is slow growing in CLL. I always emphasize the first word is chronic, so this is a chronic disease that people usually live with for many years. Okay, so we're going to do our first polling question now. So please look at your iPad. And the question is, how often do you consider biomarker testing, and this means like the FISH, IGHV, TP53, to inform treatment decisions for your patients with CLL? So the choices are, you don't use biomarker testing, only at initial diagnosis, only at first progression, at initial diagnosis and first progression, or prior to any new treatment. So please go ahead and choose one answer. Right. So a little over half of this audience is testing at initial diagnosis and first progression, about a quarter prior to any new treatment, so that's great. Some folks are not doing biomarker testing or only at initial diagnosis, so we'll talk a little bit more as we go through this as to sort of what the optimal timing is. I would say in my practice, probably at initial diagnosis and first progression. It depends a little bit when that first progression is. If it's within a few months of diagnosis, I won't necessarily retest, but if it's been a few years, I do like to retest to see where things stand. With one exception, which is the IGHV testing. So it turns out that actually doesn't change over the lifetime of the CLL patients. You never need to repeat that, but the other ones can change. Okay, so to make the diagnosis, as I've said, you have to do flow cytometry of the blood. There's a lot of confusion about this point. I see a lot of consultations where there's been a lymph node biopsy or a bone marrow biopsy. Lymph node biopsy can show SLL, small lymphocytic lymphoma, which is kind of a very close sibling of CLL. It's really the same disease, to be honest. It's just manifesting more in lymph nodes than in blood. But really, to make a diagnosis of CLL proper, you need flow cytometry of the blood. And you can see the characteristic immunophenotype there, really with the key being the expression of that CD5 protein in the context of other B-cell markers. Mantle cell lymphoma is a rare lymphoma subtype. It's another B-cell non-Hodgkin lymphoma that can sometimes look like CLL, particularly because it also has CD5 positivity. So we do generally recommend looking for a certain FISH abnormality, the 11-14 translocation, to rule out mantle cell lymphoma. I have picked up a few cases over the years that were billed as CLL, and it turned out it was mantle cell lymphoma, and that's important because the prognosis and the treatment are very different. So biomarker testing, we kind of talked about this already. I think one point to highlight again is that FISH and TP53 can change over the lifetime of a patient. So particularly in the chemotherapy days, this was very important to retest for FISH because we would not want to use chemotherapy when the TP53 is abnormal. But even today, it is helpful from a prognostic standpoint, and especially for younger patients, if you're thinking about maybe a clinical trial or a more aggressive approach like CAR T cells or even bone marrow transplantation, you want to know what their TP53 status is before you go to the next line of therapy. And that's particularly because, as we know, access to treatments and testing can vary by locations, and if you're in a more resource-limited setting, that can certainly pose greater challenges. So this is kind of an overview of the different risk stratification and prognostic markers. I've mentioned some of these FISH abnormalities here. You can see the risk. Actually, the most common abnormality I haven't mentioned yet is deletion 13q. So when we see that as the sole abnormality, that's a favorable marker. But it is still mitigated by the IGHV status. So occasionally you'll see deletion 13q, which is good, but unmutated IGHV, which is bad. Usually it's the bad one that kind of wins out over time, although not always. And actually, an example of that is there's some interesting data recently with TP53 mutation and deletion 17p. It turns out if you have a mutated IGHV, even if you have that high-risk TP53 abnormality, usually it's a more indolent disease course compared to the more typical aggressive TP53 disease. All right, so hopefully I've convinced you it's very important to test for all these prognostic markers, but I think the word has not really gotten out more widely maybe than this room, because if you look at the data here from a couple of big registries, the rates of testing are quite low across the US. So one study called Inform CLL is a prospective registry study where they looked across a variety of different community practices, and they looked at the rates of testing for these markers we just discussed. So FISH was only tested in 31% of patients. TP53 and IGHV only in 11% of patients. So certainly a lot of work needs to be done. You see a Flatiron Health EHR database as well, a little bit better in terms of FISH. IGHV still only about 24%. So we must do better if we want to have better risk stratification for our patients. And this is actually a particular challenge in Black patients compared to the overall population. Black patients with CLL are younger, tend to come in with worse performance status, often are diagnosed with more advanced stage disease, and typically, often related to that, have a shorter time until first-line therapy is needed. And you can see here in terms of the treatments that are being used, specifically in Black CLL patients, chemoimmunotherapy was still being used pretty widely even in 2019 in over a third of patients. Which is more than in comparably aged white patients. And then the rate of FISH testing was also quite low in this population at 25%. Okay, so CLL is very unusual amongst cancers because when we diagnose it, we usually don't treat it. This is very paradoxical, very hard for patients to kind of come to terms with often. Because they want to be proactive, they want to do something, but it turns out that this has been studied time and time again, and early intervention with the treatments that we've had so far does not prolong survival, but it certainly does introduce side effects, toxicities, and other things. So these are the indications for treatment. I won't go through each one in exhaustive detail, but if one of these features is met, then we do recommend treating. I'd highlight maybe the two most common ones that I see are progressive marrow failure. So when you see anemia with a hemoglobin less than 10, particularly if the platelets are also less than 100, that's a patient who likely needs treatment. I would say my practice is generally to do a bone marrow biopsy for patients with progressive marrow failure before starting treatment, even if I already know they have CLL, because every once in a while I'll pick up an MDS or something else that would require different treatment. And then other common things we see are the lymph nodes can become pretty massive over time. So particularly if they're bulky and symptomatic, or if they're causing threatening organs like kidneys and so forth, that could be a reason to treat. And some of these other ones, like progressive lymphocytosis, autoimmune complications, are less common. Sometimes you can see symptomatic extranodal involvement. Certainly symptoms factor into this. It's usually, though, again, not symptoms alone. So if I have a newly diagnosed CLL patient with early stage disease and they're having severe fatigue, that is not a patient I'm going to treat for CLL, because then I'm going to give them side effects from the treatment, and their fatigue's not going to get better because it's not being caused by the CLL. But if I have a patient whose hemoglobin is 11.5 and their platelets are 110, so they don't quite meet the marrow criteria, and they have lymph nodes that are 3 or 4 centimeters, but they're not really bulky, but that patient is having progressive fatigue, maybe they're starting to lose some weight or having some sweats, that's a patient where the symptoms kind of push me in the direction of starting treatment to get that patient feeling better, because in that case, the symptoms are being driven by the CLL.
on, we have
Yes.
a couple of really good questions. Someone wants you to repeat the test that you don't have to repeat every time.
Oh, yes. That's the IGHV test.
Okay.
Yep.
And then why do you think Black patients have more advanced disease? Is it genetics or is it just a different level of care?
Yeah, I think we don't know. I think one thing is that certainly is a genetic component to CLL. So it's a much more common disease in white populations compared to, for example, Asian populations. So CLL is pretty rare in China and Japan, for example. And when those patients move to the US, they don't necessarily have much increased risk. So some of that clearly is genetic. So that there may be a genetic component with Black patients. Some of it could also be access to care. So I think it's complicated.
Thank you.
All right, great questions. Please keep the questions coming too. That's fun. All right, so these are the NCCN guidelines for CLL. They seem to change like month by month or maybe quarter by quarter. I mean, there's just been so many new data sets reading out. And so, maybe 3 years ago at this point was sort of when chemoimmunotherapy started to move away from being preferred regimens and into other recommended regimens and now just kind of useful in certain circumstances. And then I think a year or two ago was when ibrutinib kind of got moved into other recommended regimens. So things continue to change, but as of now, you can see the preferred regimens for frontline CLL treatment in patients who do not have the high-risk disease, so without deletion 17p or TP53 mutation. You have a choice of a couple different BTK inhibitors, acalabrutinib or zanubrutinib. Acala can be given with or without obinutuzumab infusions. Both of those are continuous treatment with BTK inhibitors. And then the other choice would be venetoclax plus obinutuzumab, a time-limited combination of an oral therapy and an infusion. And we'll talk in a few minutes about pros and cons of those different approaches. You do still see ibrutinib listed there as another recommended regimen. Ibrutinib is a great drug that has really transformed how we manage CLL, but because of some of the toxicity considerations that Amy's going to discuss in a little bit, it has been relegated into this category of other recommended. And then it's pretty rare these days that we use chemoimmunotherapy. I'll show you a slide on this in a minute, but there are some listings for it in the guidelines still. But that's one really important thing to know is at the bottom there, when patients do have high-risk disease with deletion 17p or TP53 mutation, the options for preferred regimens look similar, but you'll notice there's no chemoimmunotherapy listed as useful in certain circumstances. And so we almost never say never in medicine, but you should really never use chemoimmunotherapy in patients who have TP53 aberrations. It's not effective, it's toxic, and so hopefully you have access to something else that you can use that's non-chemotherapy based. You can see even if you can't get access to some of these targeted therapies for whatever reason, you can use high-dose steroids and various other treatments like that. That's still going to be better than chemoimmunotherapy. So yeah, this is really the only slide now on chemoimmunotherapy. It really used to be a standard of care, and it was effective for some patients, especially those low genetic risk patients could do well for a while after chemoimmunotherapy. But now, really the only population where we might consider it is the younger fit patients who have mutated IGHV. The reason for that is that the original study of the FCR regimen, fludarabine, cyclophosphamide, and rituximab that was done at MD Anderson, it actually just read out with 20 years of follow-up, longest follow-up we have in any CLL study. And there were about half of the patients like this, young fit with mutated IGHV, who were still in remission 15 to 20 years after their FCR. So it is kind of still tempting to think about using it in a very young patient, but on the other hand, they had over 6% rate of MDS and AML in that study, and there's a lot of infectious complications that can arise and prolonged cytopenias. So I used FCR for a long time. I was probably one of the last holdouts who is still using it, but I haven't used it in several years now, given how good the other therapies are. That being said, if you look in that INFORM CLL registry, which is pretty contemporary, I mean, this is going up to 2020 or so, 40% of patients with unmutated IGHV, the more aggressive marker, were still receiving chemoimmunotherapy, despite the fact that even at that time we knew that there was decreased efficacy. And I've seen updated numbers, at least from sort of market research and things like that, that suggest it's still probably in the 20 to 25% range. So if you're in a practice that's using chemoimmunotherapy for CLL, it's good to ask some questions about why that's being done so much, because really the message should be targeted therapies for all patients. That's particularly true in the relapsed refractory setting. So here's the NCCN guidelines for second or third line therapy. Here again, there's not as much distinction between TP53 abnormal or not. It's really, again, targeted therapies. And sort of a useful rule of thumb is if they've gotten one class of agent in the frontline setting, then use the other class in the relapse setting. So if they started with a BTK inhibitor, then generally we go to venetoclax-based treatment in the second line setting. and vice versa. If they started with venetoclax, we can go to a BTK inhibitor. This has gotten a little bit more complicated recently with the FDA approval of pirtobrutinib for CLL, and we'll talk a little bit about that drug, but that's a drug that's also a BTK inhibitor, but you could use it after one of the other BTK inhibitors, so you could potentially go BTK to BTK and then venetoclax, but we can maybe talk about that later. All right, so I just want to show one slide each for the three main covalent BTK inhibitors that we use in practice. So first with ibrutinib, this was the original first-in-class BTK inhibitor. Again, very effective. It was compared in this RESONATE-2 trial to chlorambucil, and we've seen 8 years of follow-up from this study. At the 7-year mark, 59% of the patients were still alive and progression-free on ibrutinib, and 9% with the chlorambucil arm. There was a particular benefit in patients who have deletion 11q and unmutated IGHV because those are patients, again, who typically did not do well with chemotherapy-based approaches, and they did very well with ibrutinib. And the overall survival at 7 years was 78%. So clearly showed that ibrutinib could have sustained benefit for the high-risk patients in the frontline setting. But if you look at that 7-8 year mark, only actually about 40% of the patients were still on ibrutinib. And the most common reason why patients had to come off ibrutinib was due to toxicities. And that was about a quarter of the patients on the study had to stop the drug because of side effects. So that really inspired the development of this next generation of covalent BTK inhibitors, starting with acalabrutinib, which is a much more selective drug at targeting BTK, so it doesn't have the off-target effects leading to side effects that ibrutinib has. So the slide here is showing data from the frontline study called ELEVATE-TN, which compared acalabrutinib given either with or without obinutuzumab to, again, an older regimen of obinutuzumab with chlorambucil. And we've now seen 6 years of follow-up from this study. And both acalabrutinib arms were superior to obinutuzumab chlorambucil. And the median PFS has not yet been reached for either arm. So if you look at sort of a relative risk reduction, A plus O reduced the risk of death by 38% compared to O chlorambucil, which was statistically significant. So again, with acalabrutinib, like with ibrutinib, we have evidence of sustained benefit. We also saw very good tolerability of this drug in this study, better than what we had seen previously from ibrutinib. And then the newest kid on the block with regards to covalent BTK inhibitors is zanubrutinib. This was explored in the Sequoia study, frontline trial of zanubrutinib versus bendamustine and rituximab, which was a very commonly used regimen to treat CLL until pretty recently. And this is one of several studies that have compared to BR and shown a benefit of a BTK inhibitor. So the follow-up's a little bit shorter for the Sequoia study. It's only about 3.5 years at this point, but nonetheless, the data look very good. The PFS median has not been reached with zanubrutinib, and it was about 42 months with BR. So at that 42-month mark, about 82% of the patients were still alive and progression-free with zanubrutinib. And the benefit was in all the different genetic groups, whether mutated IGHV, unmutated IGHV, and even in patients with deletion 17p. They were actually pulled out into a separate cohort in the study, so they were just all treated with zanubrutinib. They weren't randomized, and those patients all did very well with sustained benefit. So we have these 3 BTK inhibitors approved now. As I mentioned, we tend to use mostly acala or zanu. Maybe we can talk a little bit about pros and cons of that at some point, but it's great to have these different options. All right, so switching gears a little bit now. So we were just talking about continuous BTK inhibitor-based therapy where you start on the drug and you have to stay on it indefinitely. There's been a lot of interest in the field in developing time-limited regimens, and we think to accomplish that you need to do combination approaches. And so this is the combination of venetoclax with obinutuzumab in a study called CLL-14. This was actually older patients and those with some medical comorbidities, and they were randomized to either a year of venetoclax pills with initial 6-month obinutuzumab infusions, or to a 6-month combination of chlorambucil with obinutuzumab followed by chlorambucil for another 6 months. Here showing the progression-free survival by TP53 status. So you could see that if you have low-risk disease, so no TP53 deletion or mutation, that's the top kind of dotted blue curve, those patients do very well. So you can see that the median PFS is in the range of 6 years. Excuse me. 6-year PFS, but remember this is with 1 year of treatment. So these numbers don't look too different than what we just saw with the BTK inhibitors, but that required 6 years of treatment with the BTK inhibitor pills. So if you don't have TP53 abnormalities, this is a great option. If you do have TP53 deletion or mutation, it's still a pretty good option. You can see that's the second curve down there. It's the solid blue curve. Median PFS is a little over 4 years. So it is shorter than what we see with a continuous BTK inhibitor, but remember it is with a lot less therapy. This is still just 1 year of treatment even for these high-risk patients. So it is still worth considering, Although I would say in practice, for most of my patients with high-risk CLL, I still use a BTK inhibitor. But why choose? Why not use both? So we've been asking this question now for several years, and there's, as you see, quite a few studies now looking at this. So combination of BTK with BCL2. So that way you have a time-limited therapy and you're only using pills, so no need for obinutuzumab infusion. So it's kind of the best of both worlds. And so most of the studies so far have been ibrutinib with venetoclax. You can see Captivate, a study at MD Anderson, GLOW study. They all show excellent results. You see PFS ranges in 75 to 80% range at 4 years, again with a time-limited regimen. It's usually about a 15-month regimen, so we usually start with about 3 months of ibrutinib lead-in just on its own. What's nice about that is that it can really shrink the lymph nodes down pretty quickly, get patients feeling better. It does release those cells into the blood, so it takes time for those to come down. So that's why the 3 months. But usually by the 3-month mark, that B cell count is coming down in the blood. And then we start the venetoclax, which, as you'll hear, does have the tumor lysis syndrome risks. But as long as you kind of are careful about monitoring and give hydration and do the dose ramp up, it's a very safe drug. And so this is an excellent combination. But it's not currently FDA approved in the US and probably won't be. And the reason for that is that the registrational trial for this I plus V regimen, as it's known, is called the GLOW study. You see that at the bottom. It was a pretty small phase 3 study. The comparator arm wasn't so great. It was chlorambucil based. And in the 106 patients on that I plus V arm, there were 4 patients who had sudden cardiac death. This is a signal that we've seen with ibrutinib across different studies, and it's certainly a concern with the drug. And so, we have I plus V, actually it's listed in the NCCN guidelines, but we don't have it FDA approved. We're hoping to have A plus V, acalabrutinib plus venetoclax, coming along soon. There's a registrational trial that we hope will read out soon, and that will give us access to this BTK, BCL2 based therapy here in the US. And I'm contrasting the US because in Europe, actually, they did approve I plus V, and they're using it there. I think that if you're careful about the patients that you use it in, it's reasonable. So if you use I plus V in a younger, fit patient who doesn't have any cardiovascular disease, I think the safety perspective is better there, but I think you do need to still be cautious. All right, so these next couple slides, hopefully we can have a little bit of discussion here, because I think this varies a lot, I think, between different practices, different providers, and really revolves around goals of care and continuous therapies versus fixed duration. And a lot of this comes down to patient preference now as well, and sort of this shared decision-making model. I think it's a great example of that because as I reviewed, we have great continuous therapies like BTK inhibitors. We can control the disease, we can prolong progression-free survival, and that's actually independent of response. So with BTK inhibitors, it doesn't really matter so much whether you have a CR or a PR or MRD undetectable or not. You can do well. I mean, I have many patients who've been on a BTK inhibitor for years. They're still in a partial remission. They might have some small lymph nodes still. They might have an elevated lymphocyte count, but as long as they keep taking their BTK inhibitor, they're fine. On the other hand, with fixed duration therapy, we really do want to try to maximize the depth of response. We want to eradicate as much disease as possible. And we know that without ongoing treatment, we need to do that in order to prolong the PFS. So we want to try to get to undetectable MRD. So a lot of patients that I see come in, not necessarily understanding exactly what MRD is, but they've kind of heard that's an important goal. But it actually really depends on which regimen you're using. With ven-obin, a fixed duration therapy, yes, I think that is a really important goal to try to maximize that response. But with continuous therapies, it doesn't matter at all. You don't need to be undetectable for MRD to do very well with continuous treatment. So maybe, Amy, I'll start with you. In your practice, what do you see more of from these two approaches?
So, really, it is about that shared decision making, and it's about the requirements of the visits, what we're asking of patients to keep them safe. What I find is that retired people want fixed duration. They can come, they can make trips back and forth, but they want 1 year of therapy so they can do their traveling and they can, be involved with their grandchildren's lives and not be on continuous therapy. I find that people who are working, who don't have time to come for all those tumor lysis labs and the obinutuzumab infusions, they want BTK inhibitors. They want continuous therapy. And a perfect example is I just started a physician on, and we talked this out multiple times. That's one of the best things about CLL. I can't see the people over here, I'm sorry. One of the best things about CLL is that we have time to talk about these things over and over again. So she and I had talked about this over and over and over again, and she wanted to keep working on her full schedule and not come in for all those infusions and tumor lysis labs. So she started a BTK inhibitor. And the bottom line is there's no right answer, there's no wrong answer. It's whatever fits the patient's life and whatever they're going to be adherent to.
I think logistics, I beg your pardon, I think logistics also plays an important fact. I live in Arizona. We have lots of rural patients that live in the boondocks. Having to come back and forth to this cancer center 3, 4, 5 hours, 3 times a week, are they going to choose that? Probably not. No, they're probably going to choose simpler methods. They love the orals, but they're not going to want to come back and forth that often to the cancer center.
All right, great discussion points. So as we kind of weigh the pros and cons then of frontline BTK inhibitors versus ven and obin, as I highlighted, the ven plus obi is a 1-year time-limited therapy. One of the things that's really nice about it for our CLL patients is there's no known cardiovascular or bleeding risks. Many of our older patients do have hypertension already, or they've had an MI and they have stents. They're on aspirin and Plavix, or they're already on systemic anticoagulation for something else. So that is really nice to have that option. There's less concern for long-term adherence, so patients probably stay on BTK inhibitors pretty well in the first year, maybe the second year, but certainly some of my patients, I'm a little worried the adherence to taking the drug can wane, especially if they're feeling well in those later years. And with Ven/Obi, it's that 1 year, so most patients can kind of stick with the program for at least that 1 year. I think one thing that's really nice about Ven/Obi is the potential for retreatment. So as I alluded to before, it's just that 1 year, you can get a few years of response, and then if the disease comes back, in theory, you should be able to use Ven/Obi again. We're still working on proving that. We don't have clinical trial data yet to support that approach, but it's coming. And I've actually been involved with some pharmacoeconomic analyses, which have shown that Ven/Obi is actually cost savings compared to BTK inhibitors, even at a 3-year time horizon, because even though it's 2 drugs versus 1, because at the end of those 3 years, you're still going on year after year with BTK inhibitors, so that cost really adds up year after year, not just sort of the overall cost, but even out-of-pocket costs for patients, particularly if they're in that Medicare donut hole every year paying a few $1,000s for their BTK inhibitor. But on the other hand, as you heard, BTK inhibitors are super convenient. You don't need any infusions. There's no TLS monitoring needed. We do still have a little bit longer term efficacy data. Some of the older ibrutinib studies have 10 years of follow-up now, whereas with Ven/Obi, it's about 6 years of follow-up. We do think that the BTK inhibitors given continuously are probably more effective in the TP53 aberrant population. And we still have a little bit more clinical trial data to support the sequence of starting with a BTK inhibitor and then going to venetoclax in the next line of therapy, rather than the other way around of starting with venetoclax and then going to BTK inhibitor, although we do have data supporting both approaches. So those are kind of the factors that I weigh with patients when I sit with them. All right. So let's talk about a relatively new problem now in CLL, which is BTK inhibitor resistance. We didn't have to worry about this a few years ago, but now that patients have been on ibrutinib and acalabrutinib and zanubrutinib for a few years, we're seeing that up to about a quarter of patients will develop resistance to that BTK inhibitor. So most of the data we have come from ibrutinib, since it's been around longer, but we've started to see new data sets emerging also with acalabrutinib that look pretty similar, which is that the BTK gene can mutate at this position C481. So the cysteine can turn to a serine. Why does that matter? Well, it turns out that cysteine is exactly where the drug needs to target in order to work. It's the ATP binding site of BTK. I'll show you a diagram about this in a second. So literally, the drug can no longer attach to the part of the protein where it needs to attach to block BTK. And this is a phenomenon that we've seen when we use these types of indefinite therapies. We've actually seen a similar phenomenon now with venetoclax when it's used. I told you it's mainly used as a time-limited therapy now, but when we first started developing venetoclax, it was actually given as a continuous therapy, and we've seen mutations in the BCL2 gene now in patients on long-term venetoclax. And this is mostly in patients who have had other prior CLL treatments and have TP53 abnormalities, but not exclusively. So we see these types of mutations also even in the frontline setting. All right, so here's a little diagram that gives you a sense for what I'm talking about. So on the left there is the covalent BTK inhibitors we've been discussing so far, ibrutinib, acalabrutinib, and zanubrutinib. And you can see that little C, the C there in the BTK is the cysteine. So, and then the drug is the darker gray circle. So when the cysteine is there, the drug can target the cysteine and it can inhibit the BTK. But when that cysteine switches to a serine, the S, the drug can no longer bind. And so then the protein can continue to signal, and the patient develops progression of the CLL. So that's why this new class of non-covalent BTK inhibitors is pretty exciting. So there's two of them, pirtobrutinib, which is FDA approved. It's got an accelerated approval for CLL now in the double refractory setting. And then nemtabrutinib, which is still in development, not yet FDA approved. But you can see that just even schematically there, these drugs bind to BTK in a different way. They kind of wrap around the cysteine rather, so that if the cysteine mutates to a serine, these drugs don't care. They can still bind in the same way they normally bind. And so they're able to continue to inhibit BTK even in the presence of a serine. Now, there are other mutations that can disrupt the non-covalent BTK inhibitors, but at least once we see these covalent BTK inhibitor progressors, they usually have this cysteine to serine mutation, and therefore they usually respond to non-covalent BTK inhibitors. So this has been demonstrated nicely now in a very large study called BRUIN. This is a 773 patient phase 1/2 study that just kept growing year after year as there was a lot of excitement about this drug. So it was not just CLL, it was a lot of other B-cell malignancies like mantle cell lymphoma, but for the purposes of this evening, we'll focus in on the CLL patients. So there were 317 at this latest analysis here. You can see that 282 of those CLL patients had had a prior BTK inhibitor. And then they looked at a population of 247 who had progression or intolerance to a prior covalent BTK inhibitor. One interesting curve that I like on this study that they showed is the progression-free survival, whether there's that BTK C481 mutation or not. And you can see those curves are pretty overlapping. So it kind of supports what I was suggesting before, that this drug doesn't care whether there's a serine or a cysteine there. It can still be equally effective. And so maybe starting in the top right, this is a little bit of a busy slide, but I like the waterfall plot in the top right. So each line there is a different patient, and what we're looking at is the decrease in the lymph node diameters, and the darker shading there represents patients who had previously progressed on their BTK inhibitor, whether it was ibrutinib or acalabrutinib. The lighter bars represent patients who had come off ibrutinib or acalabrutinib due to side effects. And then it's a little hard to see, but the little asterisks there at the bottom of each bar represent patients who also previously had venetoclax. And you can see, regardless of the reason why they had to stop their prior BTK inhibitor, and even if they had had venetoclax also, these patients typically had a very nice decrease in their lymph node size. If you look at the overall response rate, it's a little bit over 80% of patients had at least a 50% shrinkage of their lymph nodes. And you can see in the lower right that the median progression-free survival was in the range of about 20 months. It was a little bit shorter in patients who were in that double refractory population, so post-BTK and post-venetoclax, but still close to 17 months. So this really does suggest pirtobrutinib is a very helpful new option. Just to put these numbers in perspective, like median PFS of 17 months, there's some earlier studies that suggested before pirtobrutinib, the median overall survival for this population was only 3 to 6 months, so pretty dismal. And now seeing progression-free survival of 17 months, and some of these patients are then getting bridged to other therapies and living even longer. So this has really been an important new drug for CLL, and it was just FDA approved for CLL in December of 2023. I'll mention also that it's very well tolerated, so it's a very easy drug for patients as well. All right, so I think I just have a couple more slides here just to kind of highlight a couple of different scenarios. So one is what I was alluding to before, venetoclax after a BTK inhibitor. How effective is it? So this is a retrospective study of close to 100 patients, and about 60% of these patients had received just a prior BTK inhibitor, 25% had received a PI3 kinase inhibitor, 10% had received both. And you can see on the left that the PFS looks quite good for venetoclax in this setting. Median not yet reached in the top line there. The top line is patients who had to come off their prior B-cell receptor pathway inhibitor because of reasons other than progression, so mostly toxicity. For example, patient went on ibrutinib, came off because of AFib, and then went on to venetoclax, so they're likely to stay progression-free for a very long time. There were patients who had progressed on their prior BTK inhibitor or PI3 kinase inhibitor. They still did pretty well, but that's the dashed line there, so not quite as well. So I think it's a great option to use venetoclax after BTK inhibitors, and certainly one we use commonly in our practice. And then finally, my last slide, I just wanted to mention a little bit of the data around Lysocell, just to give you a perspective on that. So Lysocell, again, is the anti-CD19 CAR T-cell product. You may be familiar with it from other lymphomas where it's approved, but it just was approved last month in CLL. And that was based on this study called Transcend 004. This was a very heavily pretreated population, median of 5 prior lines of therapy. Most of these patients had had a couple of different rounds of chemo immunotherapy in the more distant past, and then more recently they'd had a BTK inhibitor, and then they'd had venetoclax, had sort of run out of all options, and then came on this study. And so there were 50 such patients who were in that double refractory population. And you can see there with CAR T that the overall response rate was about 44%, and 20% of that population achieved a CR. So it's certainly active in some patients. Some of those patients also achieved this undetectable MRD. Interestingly, of the patients who achieved CR, all but one of them have actually stayed in a CR at the 2-year mark. So if you can get to a CR, it's likely to be durable. But the problem is only 20% of patients are getting into a CR. So I think it's a good proof of principle. It is a product that I would consider for my patients who meet these criteria. But I'm hopeful that we'll be able to develop more effective strategies for CAR T and CLL, and that might involve using it in earlier lines of therapy when patients aren't quite as refractory, maybe combining CAR T with other drugs like BTK inhibitors to get them to work a little bit better. So still a lot of work to do in the clinical trials space to optimize CAR T and CLL, but it's nice to at least have one approved option now for our patients. All right, so I think with that, do we have questions maybe?
Yes,
yeah,
yes.
okay.
So before we go on to side effects, there are some good questions for you, and I just want to make sure everyone's aware we have a virtual audience as well. Keep your questions coming, both in the room and virtually. So are you looking for MRD in blood, bone marrow, or both?
So we look at both in clinical trials. I would say increasingly I'm looking more in blood, particularly because we now have access to this adaptive clonoSEQ assay, which is a next generation sequencing assay that's been FDA cleared in CLL and is very accurate and helpful, and it's done in the blood. And because it can get down to very low levels, it's probably just as good as testing in the bone marrow and a heck of a lot less painful.
Okay, great. And then when do you look for resistance mutations, and what does that look like?
So I look for resistance mutations pretty frequently when patients are just on BTK inhibitors, but that's just for research purposes. I'd say in clinical practice, when I would start to look for resistance would be a patient, for example, who's been on a BTK inhibitor for a while, and then their white blood cell count is starting to rise, or they're starting to develop lymph node progression. That's a good time to look to get a sense for what's going on.
Yep. And then do you know off the top of your head, and you may not, I actually think you'll know this, the reference, somebody's looking for the reference for the pharmacoeconomic data on VEN and OBIN. Do you know any of the first authors or any of that? If
I
not,
am an
we can-
author on that paper,
Oh,
so
there
if you
you
search
go. Okay,
David's
there
MS.
you go. Okay, well, he does know.
Yeah, but I don't remember the first author off the top of my head. It was not me.
It was not you?
No.
Okay. Okay, all right. And
don't ask me questions about economics. I was the clinical advisor for CLL.
Keep the questions coming. A lot of these we are going to answer as we go on. Some of you are way ahead of us. So just hang on and we'll answer some of these as we go. So I am going to talk about adverse events with BTK or with our oral drugs, our targeted therapies. But for all of you, scanning this QR code is a digital online pocket guide for oral oncolytics. And it has information on assessing patients and their goals for therapy and quick references for adverse events and the management of adverse events. So this is a great tool for nurses who are seeing, a lot of you are seeing every disease under the sun. So to have these quick resources for your CLL patients is perfect. So Dr. Davids talked about our covalent versus our non-covalent BTK inhibitors and the data behind them in terms of responses and the efficacy of these agents. And so what I'm focusing here on is the side effects, right? And so ibrutinib was our first generation BTK inhibitor, and it's the least selective BTK inhibitor, meaning it hits the most off-target, it has the most off-target effects, so has the highest side effect profile. And that's why it is now it has fallen off the preferred regimen. It's an other. You can certainly use it, but because of the safety, which we'll talk a little bit about more, of acalabrutinib and zanubrutinib, those have come to the top of the NCCN guidelines. And so you can, with the way I like to think about this is with each iteration of this family of drugs, they're more selective and they have less toxicity. And so it's that off-target TEC effect that is thought to cause the bleeding and the cardiac toxicity. And then for those of you who treat solid tumors, you are all over EGFR in terms of the rashes, the diarrhea, the arthralgias and myalgias. You know that well, and that is just an off-target effect of our BTK inhibitors. And so looking at common toxicities, so we've talked about the arthralgias and diarrhea and rashes, but bleeding, again, most patients will have minor bleeding. When they're brushing or flossing their teeth, when they're blowing their nose, they might have easy bruising. Some will have petechiae. It's usually very mild bleeding that you're really not going to do anything about other than encourage them, don't use a razor blade, use an electric razor, just those sorts of things. But hemorrhage is possible. It's a low volume occurrence, but it does happen. AFib is another one. Hypertension. The unique thing about hypertension is that it is the only side effect that gets increases in incidence the longer patients are on it. It's typically not something that's happening initially, like the nausea and diarrhea and those things that tend to get better. That's something that happens years into it. And you can see the fatigue and ventricular arrhythmias, which Dr. Davids had talked about, being a significant side effect, most commonly with ibrutinib, but can happen with any of them, and cytopenias as well, and fatigue. And then, so if you look at common adverse events that are seen in 25% or more, you can just, in an instant, see that the side effect profile gets more attractive as we get new agents in this family. So the most side effects are with ibrutinib, and then less with acalabrutinib, and even fewer with zanubrutinib and pirtobrutinib. And like Dr. Davids had talked about, pirtobrutinib is very, very well tolerated. So serious adverse events with BTK inhibitors. So most of these are very low incidence. So hemorrhage is a very low incidence issue. AFib, aflutter is highest in ibrutinib, and then as we go down the list of FDA approvals, it gets less. But certainly your high-risk folks or your older folks, males, history of AFib, and a whole host of cardiac histories, hypertension, hyperlipidemia, pre-existing cardiac disease. Those are the patients who are most likely to have AFib, although you could have the 40-year-old woman develop AFib too, but it's more likely going to be these higher risk folks. Infections are common with all of these, but severe infections are not exceedingly common. Cytopenias are definitely seen with these, and as well as second primary malignancies. And if you go down that list, they're very similar rates, and the most common second malignancy are non-melanoma skin cancers. So really making sure patients are wearing sunscreen and staying covered and are not beach bums is definitely an important thing, an education point. So then management of these adverse events. So AFib, if you have a high-risk person, I don't know what you do in clinical practice. We typically will get a baseline EKG on these folks we're worried about. If it's somebody without risk factors, we're not automatically. Are you doing EKGs on folks, everybody, or just your high-risk folks?
Probably should be doing them on everyone just to get a baseline, but yeah, definitely on the high-risk folks we do.
Got it.
Yeah.
And then the AFib is treated just as you would treat without being on a BTK inhibitor. Certainly, if it's not easy to control, you are going to discontinue the BTK inhibitor. You're going to hold it to get them under control. The preferred anticoagulation are DOACs, just because those are reversed very quickly versus our warfarin and our low molecular weight heparin, which people hate, right, to do and self-inject. And then bleeding, we're monitoring patients. The one critical thing that I talk to patients every time I see them who are on BTK inhibitors is this need to hold the drug for 3 days or 7 days, both before and after procedures or surgeries or anything invasive. And what I tell people is just shoot me a message if you're having something done. Like, even if people have periodontal disease and need these very deep cleanings, they should be holding it for 3 days before and after. So I just tell them, just shoot me a message, let me know what you're having done, I'll tell you how long you need to hold it. But it is really important that patients do that so they don't have significant bleeding during procedures. Diarrhea is typically, loperamide typically helps that. Headaches is really the hallmark of acalabrutinib. They typically last a couple months after initiation of therapy, and they are very, for most patients, easily controlled with acetaminophen and caffeine. And so this is a good time to remind people not to take NSAIDs, right, because that increases their bleeding risk. So acetaminophen needs to be their go-to analgesic for, everything that they need analgesic for. And then hypertension, again, this is a treatment emergent. The longer patients are on it, the more we see this. And it's managed just as you would normally manage hypertension, but when you stop the BTK inhibitor, patients may be able to go down and potentially off their antihypertensive. So that's something to make sure they're aware of. Infections, so prophylaxis should be considered. I don't know what we're giving everyone antiviral prophylaxis who are on BTK inhibitors. What are you doing?
Not necessarily in the frontline setting. For patients who've had prior chemo and then they go on a BTK inhibitor,
Yes.
definitely. But yeah, sometimes we have patients who've had a lot of infections over the years, then we will, but yeah.
Yeah, absolutely. But every patient needs to be evaluated. And some of it is what are their immunoglobulins as well, and what does their infection history look like. These arthralgias and myalgias, I find these to be the hardest. This is the hardest thing to manage with BTK inhibitors. They are so subjective, and typically I try to use acetaminophen. You can give patients short courses of steroids to try to improve this, but this is one of the stickiest things to manage.
Yeah, I mean, we're going to talk about Acala and Xanu in a minute. That is one thing I will say that's nice about zanubrutinib is it's 4 pills, so 2 pills twice a day. So I've found, especially for myalgias, arthralgias, you can really titrate the dose because you could do 1 in the morning, 2 in the evening, or vice versa. Whereas with acalabrutinib, it's just 1 pill in the morning, 1 pill in the evening. And if you go down to once a day, you're probably not getting great BTK coverage.
Right.
So the flexibility of zanubrutinib for this particular toxicity, I think, is really nice.
Agreed. And when we only had ibrutinib, we worked through a lot of these side effects. But now that we have drugs that are tolerated differently, I think we're all switching agents before we're doing lots of dose reductions to maintain that therapeutic dose. So neutropenia and thrombocytopenia, again, these happen. Growth factor is commonly used for these folks to try to keep them at target doses. But, interruptions help as well. And then rashes are typically responsive to topicals, steroids or topical or oral antihistamines. So all of these side effects are quite manageable in the average patient. And so I talked about ibrutinib having the highest side effect profile. And so again, remember, and Dr. David showed us this data where the progression-free survival, Acala versus ibrutinib, and overall survival are essentially identical. But where the big difference comes in is this incidence of AFib and hypertension. So the reddish is ibrutinib, and you can see that the AFib and the hypertension rates are visibly higher than with acalabrutinib. Again, this is why ibrutinib is not a preferred agent in this setting. And then this also holds true with zanubrutinib versus ibrutinib, but in this Alpine study, it actually looks like the progression-free survival is improved with zanubrutinib. So whereas it was identical with ibrutinib versus acalabrutinib, zanubrutinib does look to be a superior agent to ibrutinib in terms of progression-free survival. And we'll see what happens with overall survival as time goes on. But then if you look at the AFib, aflutter rate, comparing zanubrutinib to ibrutinib, you can see that clearly the zanubrutinib has a much lower incidence of AFib and aflutter. So again, just solidifying. I heard someone say that ibrutinib should get the Nobel Prize and then retire, right? Because this was really revolutionary, and but it's yep. So let's talk about sequencing. Okay, so what happens when you have someone with an unacceptable toxicity or a hugely problematic toxicity. If they're on ibrutinib and you move them to acalabrutinib, you can see here of these 41 patients, only 24 had recurrence, but the majority had lower grade recurrence. So switching from ibrutinib to acalabrutinib is definitely an option for tolerance issues. And then what about zanubrutinib? So this data shows zanubrutinib for patients who are intolerant to either ibrutinib or acalabrutinib. And this was 87 patients, and 83% did not have recurrence of their toxicity. So you can see here the majority of things did not recur. So switching for tolerance to zanubrutinib is definitely a good option. And so let's go to a question. Ms. Y starts acalabrutinib 5 months ago for CLL and has had persistent arthralgias. Despite following all the suggestions to alleviate her pain, the arthralgias persist and they're significantly impacting her life. What other options would be appropriate given her intolerance to acalabrutinib? Should she go on zanubrutinib, zanubrutinib or pirtobrutinib, zanubrutinib or ibrutinib, pirtobrutinib, or I don't know? And I appreciate the I don't know. Great. Okay. So we have a really good slide on this, and so okay. So we're saying, okay. Can you go back down? Okay. Wonderful. So the correct answer is zanubrutinib or pirtobrutinib, and we saw lots of. But zanubrutinib is not wrong either. That's a little bit of a tricky question. So the majority are getting that right. So thank you. Drug-drug interactions, this CYP3A pathway is the bane of our existence in oncology, and it is keeping our pharmacy colleagues busy and in full-time employment and was going nowhere anytime soon. So lots of drug-drug interactions. I'm not going to go through this in great detail. You've got these in your downloadable slides. And so there were questions on this, so sequencing therapy. So if a patient is resistant to a covalent, so our ibrutinib, acalabrutinib, zanubrutinib, switching is not going to work. Remember, Dr. David showed us that resistance mechanism. So once the binding stops with the covalent BTK inhibitors, switching agents is not going to help. So if someone is resistant, you're going to switch to pirtobrutinib because remember, it hooks on differently. So you're going to go to a non-covalent. So for intolerance, if a patient is on a covalent, so if they're on ibrutinib, you can switch them to any of these others, acala, xanu, or pirtobrutinib. And again, acala, if you're not going to go backwards in general, but if they are intolerant to acalabrutinib, you can try xanu or pirtobrutinib. If they're intolerant to zanubrutinib, technically you can go to acalabrutinib. I don't do that. Do you do that?
I've done that actually, like specifically for hypertension, which
Oh,
I think is a little more with
Okay,
Xanu.
okay,
Yeah.
fair enough. Okay, or go to pirtobrutinib for zanubrutinib intolerance. And then I'm not. This is just the dosing, and again, you've got this in your slides. So let's go to another question. Mr. J has been on initial therapy with ibrutinib for over 7 years for CLL. He's progressing, and his molecular analysis finds that he's got a C481S mutation. He asks if he's still able to remain on a BTK inhibitor. What are his options? There is no option. He's got to discontinue BTK treatment. Can he go on zanubrutinib? Can he go on pirtobrutinib? Can he go on acalabrutinib, or you're not sure? There's not more than, well, I don't know, well, it's certainly an answer, but the answer is pirtobrutinib. Right, so he's resistant to a covalent BTK inhibitor, so switching to another covalent, he has that resistance mutation. So pirtobrutinib is the only BTK option for him.
Can I maybe make a
Yes.
comment on this one too? If you could scroll back up to the top, there was a choice about not being able to be on a BTK inhibitor. He must discontinue treatment with a BTK inhibitor. So just one point about this is that when you're transitioning therapies, it's really important that patients stay on the prior therapy until they move to the next therapy. So I've seen this several times now where a patient is not responding to ibrutinib anymore. The oncologist stops the ibrutinib and then waits a month or two to get them on the next therapy. And the disease can flare during that time. The patients can get really sick and can be hard to turn things around. So if you're switching to pirtobrutinib here, you want to continue the ibrutinib all the way up till the day before you start the pirtobrutinib. And then you're about to hear about venetoclax, kind of the same thing, at least up until starting the venetoclax. And sometimes we'll even overlap it with the venetoclax to reduce that risk.
No, that's a great point. Thank you. Thank you for making that point. So we've talked a little about the venetoclax data and the ramp up. And so those of you who are not familiar with the ramp up, patients get 20 milligrams for the first week, and then 50 for the second week, 100, 200, and then it's not till that fifth week they go up to their full 400 milligram dose. And this is because in the early clinical trials, there were fatal episodes of tumor lysis syndrome. And so with this ramp up, there have been no tumor lysis fatalities. So this has been a very effective approach to making venetoclax very safe. And so common adverse events. So I want to go to the right first. So grade 3 to 4 neutropenia occurs in about 40% of patients on single agent venetoclax, but increases to about 60% when you use an anti-CD20. So neutropenia is a very common issue. And then when you fold in a BTK inhibitor, like Dr. Davids was showing us earlier, that grade 3 to 4 neutropenia goes up to 70%. But fortunately, the rates of febrile neutropenia are quite low. So even though patients are getting neutropenic, they have very few neutropenic fevers. So then other common issues, again, diarrhea, nausea, infections, myalgias, pain, very similar to the BTK inhibitors in general, but typically much more well tolerated than BTK inhibitors. So serious adverse events, again, it's impossible to say the word venetoclax without thinking about tumor lysis syndrome. Again, we've got this ramp up. The rates of tumor lysis syndrome are about 2%, and we see a lot more laboratory than clinical tumor lysis syndrome. And then, again, the CYP3A pathway is a no-no for these folks. And then fatal and serious infections have occurred in patients getting venetoclax with or without an anti-CD20. So tumor lysis syndrome, again, ramp up. Every patient gets a tumor lysis risk assessment done. It's based on their lymphocyte count, their lymph node burden, the size of their lymph nodes, and then renal function as well. And so patients at low or medium risk are typically treated outpatient, but patients high risk get those first two dose escalations as inpatients. And then every patient gets tumor lysis monitoring, and it depends whether they're low, medium, or high risk for tumor lysis syndrome. The schedule's a little different between the low and medium and the high risk folks, but you're really looking for potassium, which increases in tumor lysis syndrome, increased uric acid, increased LDH, increased phosphorus, and decreased calcium. So all these patients also get tumor lysis prophylaxis. They should all be on allopurinol, and they should all be hydrating vigorously, regardless of their risk. So really trying to prevent tumor lysis syndrome. Go ahead.
Can I just make a couple comments on that too?
Yeah.
So one is that part of that risk stratification for lymph node size includes a CAT scan. So a lot of hematologists will say it's CLL, I don't need to get a CAT scan. If they're going on venetoclax, they need a CAT scan.
Yep.
Because you need to understand what the lymph node size is, and sometimes you can have internal lymph nodes that you can't palpate that could be 7-8 centimeters, and that's a patient who's at high risk for TLS.
Yeah, absolutely.
Second point is that we often flood these patients with IV fluids to reduce that risk of TLS, and then they get edema. Sometimes we even see heart failure. So you need to be a little bit careful, and sometimes you need to give a little bit of Lasix to kind of counteract that and keep patients a little bit more even. So it's kind of one of those weird situations where you're giving fluids and Lasix, but it really makes sense because otherwise these patients get very fluid overloaded.
Yep, and that's somebody's asking about echoes. Do you ever do echoes prior to treatment?
I don't do it routinely outside of clinical trials, but if it's a patient who's had cardiovascular issues over the years, I might, just to see where they're at.
Okay, great. And then, so when you're starting somebody on a venetoclax-based regimen with an anti-CD20, you're asking, can this patient stay hydrated? We all have these 80-year-olds who drink like 8 ounces of water and a cup of coffee, right? These are really, they make me very nervous. We really need people to stay hydrated. Can they be compliant with medications? If anybody has ever seen that venetoclax ramp up, it's color-coded, there's a calendar, it's beautiful. It's really hard to mess this up, but it can be messed up, right? So can the patient be compliant with these medications? And do they have transportation like Nikki was talking about? Can they make all these trips back and forth for infusions and tumor lysis syndrome monitoring? It sounds like a great regimen, but not everyone can fit that into their life. So obinutuzumab, hard to talk about obinutuzumab without talking about infusion reactions. They can be immediate and they occur within an hour of the infusion, or they can have delayed infusion reactions. I see it typically the next day, but it can be up to a week later, and these are immune system mediated, and because of these reactions, every infusion needs pre-medications, and then hopefully within your practice you have algorithms or some standardized orders or ways that you can just immediately act upon these reactions, because it does require prompt assessment and management. So if you've got your standing orders, that makes it much, much easier. So let's do one more question here. Mr. B is starting venetoclax and obinutuzumab as initial therapy for CLL. You explained the need for frequent blood testing in the first 2 months to monitor for electrolyte abnormalities, tumor lysis syndrome, hyperlipidemia, transaminitis, or I don't know. Great. So tumor lysis syndrome, that's perfect. Yep. Thank you. So our key takeaways here are that our BTK inhibitors and our BCL2 inhibitors are widely used in CLL. They are here to stay. We've got our 3 covalent BTK inhibitors that are safe and effective, and our non-covalent BTK inhibitors can overcome that resistance. We've got pirtobrutinib. The next one that's likely to come is nemtabrutinib. So we've got others in that non-covalent family coming. Combination regimens are being used and are being widely studied. We now have CAR-T for CLL, which is exciting. And then shared decision-making, which Nikki's going to talk about, is really important here. And then all of you really, this ongoing education monitoring is just so critical to the success of patients on these therapies. Let's give that to Nikki, and keep the questions coming, everybody.
So let's talk about some patient-tethered treatment approaches, incorporating some strategies to address these patient-related treatment barriers. Patients hear, hey, I'm going to be an oral drug. Yes, that's so much easier. It's not chemotherapy. I won't get sick. As we've heard, boy, can they, huh? Patient engagement. These agents are oral. Some of them are novel agents. Can be combination with an infusion or infusion alone, or combination of oral and IV therapies. We've talked about the duration, fixed versus continuous duration therapies, and that time to achieve that all-important, undetectable, measurable disease, residual disease. Are we looking for disease control, or are we looking for a deep remission? Toxicity profile and patient comorbidities. We've heard if they've had heart conditions, we might want to choose our drugs a little differently. And how's this last one for you? Cost. How much do these drugs cost? I did a little Google search just to see what did Dr. Google have to say for ibrutinib. $17,000 a month for a standard dose for ibrutinib. That was in 2023. Maybe going down a little since it's not as popular drug anymore, but $17,000 a month. Wow. Key components for patient counseling, we want to make sure we talk about the dosing, administration, and dosing schedule. What to do if you miss a dose? Oopsie, I skipped my dose, I forgot it. Do I take it late? Do I just skip it? What do we do? And that storage and disposal of unused medication. Do we want these medications in the garbage or down the drains? No. Something about the dosing that I learned the hard way as the oral anti-neoplastics nurse navigator, try to say that. I was talking to a patient. Hey, you taking your medication? It wasn't for CLL, so I won't mention the drug. He's like, yeah, I'm taking it. I'm like, okay, how often are you taking it? I'm taking it once a day. Okay, check that little box. I kept going. The next day he calls me. He's like, I'm having some paralysis. I'm like, pardon me, come again? So we brought him in to see the doctor that day. Guess who was doubling his dose? So from now on, I say, tell me how you're taking the drugs. Do you take it in the morning? How many pills are you taking it? Are you taking it in the afternoon? What time are you taking them? Are you taking them at 10 o'clock in the morning and 4 o'clock in the afternoon? I'm much more specific. I learned the hard way. Luckily, this guy was okay, but you got to be pretty specific. I learned the hard way on that one. Tell me more. Any drug-to-drug interactions, we've heard about the importance of those, and drug-to-food interactions. Can patients eat grapefruits and grapefruit juice and Seville oranges and all that while they're taking some of these medications? No. Nope, sure can't. Most patients are okay with that. I pucker even thinking about it. Some really have a hard time with that. And we talked about the common and rare side effects, signs and symptoms, and self-monitoring at home. When do we want patients to call us? I tell them, call me all the time. I can tell you it's okay, nothing to worry about, we'll look at it again tomorrow, or, oh boy, this is something we need to get on right away. If a patient's having an elephant sitting on his chest, am I going to want them to call me and tell me about it? No, I'm going to want you to call 911, please. So there's certain times where don't call me, go right to any mental status changes, anything like that. That's a 911. Shared decision making, we touched on this earlier, making sure we are having patients participate in these discussions, helping them be involved in making the decision of which medications to use. As Amy said, this can take a while. It can take, we have some time. We can research all the options with you. Assess your patient's values and preferences, reach a decision with your patient, and evaluate your patient's decisions. Informed decision-making is not shared decision-making. It's not Dr. Davis just saying, here's your options, okay, you choose, and, bye-bye. You got to actually talk to them about it. What are your preferences? What do you think? I gave you a lot of information. Let's talk about it. What did you hear? It's a back and forth flow of information. Are they going to hear it all the first time? They just heard they have leukemia and we're not going to treat it. They're gone. Their mind is spinning. So this takes time, lots of discussions. The goal is to create an alignment with the patient at every juncture, treatment naive and then relapse refractory settings. It's important to meet the patients where they're at. Some patients are going to say, I'm not going to be treated. I don't want to know all this stuff. I'm not going to be treated. I've got leukemia. I'm just not. Meet them where they're at, provide a little more information each time for them. Making sure we're overcoming any challenges such as social needs, financial barriers, and language barriers. This medication, one of them is $17,000 a month. Obviously, we're not going to let any patients pay that. Even a copay, that means they may not be able to go and afford groceries. We're going to pull in a social worker for that. All of that kind of stuff. Language barriers was always still a really hard one for me, having to use a translator. Things just get lost a little bit in translation. That was a pun, sorry. Considerations when recommending treatment to your patients, using a patient-centric approach. Patient factors such as we've talked about, the comorbidities and those past medical history, and therapy factors such as the adverse events. along with the goal coordinate care, we're going to again understand the patient goals, make sure we set those expectations together, and realigning expectations as needed. If a patient just says, well, I want to be cured, well, we need to revisit this again. Let's start again. And how are we going to measure success? How is the patient going to measure success? Education by an oncology pharmacist, an advanced practice provider, or an oncology nurse with planned follow-up is very, very, very important to optimizing care for these patients. We don't just put them on these medications and say, okay, we'll see you at your 3-month follow-up or your 3-week follow-up. How many people would still be taking the medication if they were having side effects? They'd stop it, right? And then you wouldn't know for another 3 weeks. Many specialty pharmacies conduct their own refill outreach, adherent assessments, quality of life, etc. This is hard for me as a nurse because patients say, well, I told somebody. They don't know who they're talking to. I talked to the pharmacy, but that pharmacy may not necessarily be talking to me, so it may not get to the patient chart for the provider to know and our pharmacist to know. So that one's a little bit sticky for me. I tell the patients, I'm your first call. Call me, please. You can follow up with the pharmacy also, but please let me know first. We want to make sure we use a team approach to prevent or promptly manage adverse events. This is critical for patients to continue to taking these medications. These poorly managed AEs can compromise adherence and the quality of life and outcomes. Adherence impacts the outcomes. Poor adherence of ibrutinib, meaning missing 8 doses, that's not a lot. Missing 8 doses was related to worse progression-free survival, and this can be applied to other oral therapies also. At my institution, we developed an oral anti-neoplastics program with the goal to reduce severity of the side effects, reduce ER visits, reduce hospitalizations, reduce cost, increase adherence, and increase patient satisfaction. At the time, we were also meeting the OCM requirement. The key components was the oral anti-neoplastic nurse navigator, or the OWN, because that's way too hard to see every time. The oral patient pharmacy advocate, we're going to talk about what each of these people do, the oral anti-neoplastics pharmacist, and of course, we team with the providers, the nurse coordinators, everybody in the clinic. So the oral anti-neoplastics patient advocate is my right hand. I cannot do this without her. They process all the prescriptions, submit prior authorizations to insurance, and determine if there's a need for a specialty pharmacy. A lot of these drugs you can't just go pick up at your neighborhood drugstore. They also apply for financial assistance. This is huge, huge, $17,000. This is huge. Patients need this, and it's wonderful to have somebody monitoring this for them. Once the medication's been approved, they're going to notify the OWN and the provider team when the script's ready to be filled. As the oral neoplastic nurse navigator, I make sure the chemo consent is completed and signed, meet or call with the patients to provide that patient-tailored anti-neoplastic education. I update that all-important medication list so we make sure there's no drug-to-drug interactions, and I implement a follow-up algorithm. And our pharmacist evaluates for on-label, off-label indications, which makes a difference with insurance approvals, and evaluates for these huge potential drug-to-drug, drug-specific treatment requirements. How many of our patients are taking lots of supplements? I mean, pages. I don't know if they interact or not. I have no idea, but boy, does my pharmacist. So it is definitely a team approach. The oral anti-neoplastics program, here is the nurse navigator. I initiate a tailored anti-neoplastic education. Let's talk about the diagnosis, the goal, and how long you're going to be on treatment. How to take it, what schedule you're going to follow. How do you remember to take your medications? Do you need to set a phone alarm? Can you just remember? Do you use a pill box? Can you put all your medications in one pill box? The answer is no. You're going to use a separate pill box for these medications. So we go through it, really the nitty-gritty. Drug food, can I eat when I take this? Do I have to wait for a couple of hours? Safe storage and handling. This is important for everybody in the home, the caregivers included. expected AE management or symptoms and management strategies, including prescription drugs and any over-the-counters, signs, symptoms that require emergency management, how to obtain refills, yada, yada. We're running out of time. I'm going to keep going. Follow-up phone calls to these patients at least every week for 2 weeks. At least I'm calling them every week for 2 weeks. If they're having side effects, I'm calling them way more often than that. After that 2 weeks, if things are going well, I change the algorithm to every 2 weeks times 3, getting them through that first and second month. Make sure they're taking the medications as prescribed. Don't make the same mistake I did. Ask questions very pointed. If not, why not? Why are you not taking the medications? What happened? We make sure we use the CTCAE grade for AEs so that everybody's talking the same language when we're talking about the adverse events. And we're talking about whether or not the AEs can be controlled with home medications. And if it's an important AEs and patients need to get into that clinic today, we work with the providers and our team to get patients in there to be seen. I'm sorry, I know that was fast.
Thank you, Nikki. And then, so our SMART goals. So this is our roll-up to take proactive measures to manage adverse events, educating patients on self-monitoring, on early and late side effects of the therapies, addressing common barriers to CLL therapy adherence with our multidisciplinary team. Someone asked about low socioeconomic folks. This is where our social workers, our pharmacy folks, we get people hooked up with medical assistance, and all of these drug companies have programs that people with a true financial need essentially get free drug. And, you know, we really do work hard to make sure that everybody has access to these drugs. But it does take a team, you know, to get people started and to make sure they're being adherent and getting the most out of these therapies. And then implementing a structured patient counseling program to educate our patients, you know, including looking at their risk category, their genetic markers, treatment goals, really trying to empower patients to do this shared decision-making, because again, there are no right or wrong answers for patients. So our question and answer, I'm going to go through some of these questions. We still have a whole iPad page of questions to get to. But please make sure you're claiming your credit. Scan the QR code, create an account, complete your pre and post evaluation, get your credits. You were here. Please get your credit for being here. Okay, so let's start with some questions. So somebody's asking, they can't get to the link to the presentation. Can they, okay, yep, we'll take care of you, whoever asked that question. So someone's asking, have you used home infusion or hydration or at-home lab draws? And I'm assuming you mean for the venetoclax ramp up. It seems like that should be an easy thing to do, but it's not, because we have to evaluate these patients. The turnaround for the labs is critical, and that's really that's why they have to come in to see us, because we have to have these labs back within a couple hours, because if they have tumor lysis syndrome, we need to be acting on this. If we're doing those through home care or at their Quest or LabCorp, I mean, it might be 2 or 3 days before we have those results, and that defeats the purpose of that tumor lysis monitoring. So in general, no, that's because we really need quick turnaround. So let's talk about cardiology. Do you work closely with cardiology, and do cardiac issues delay patient treatment?
Yeah, I mean, we're fortunate at a large center. We have an oncocardiology group with a couple of different folks who specialize in that area. But I would say, you know, if you don't have access to that, I think finding a good cardiologist who you can partner with in the community, someone who's willing to kind of learn about these drugs. I feel like for most general cardiologists, they've heard of BTK inhibitors, but they don't necessarily know too much about them. But if they're willing to learn, I think it is important to have someone like that who can be a go-to, because things come up with these BTK inhibitors. Even with acalabrutinib and zanubrutinib, although the rates of AFib and hypertension seem to be lower, they're not zero. I mean, we still see these things popping up.
Yeah. And then we have a couple related questions. So one is asking how you taper once patients are disease-free for 5 years. And can you dose reduce if patients are maintaining a a good response. That's very CML-like.
Yes. These are great questions
Yes.
that are actually being studied now in some trials, but
Yes.
we really don't have much data on them yet. And so it's not something I'd recommend doing outside of a clinical trial setting. All the trial data you saw to achieve those results, you have to continue on the BTK inhibitors. You can't taper down the dose. You can't stop them at 5 years. There's no data yet supporting that. I'm hoping that we'll have some data like that because I think it's certainly possible that patients may do well with a treatment holiday of maybe a few years and then could come back to a BTK inhibitor, but we just don't know.
And I just remember how long it took our CML colleagues to sort this out for their tyrosine kinase inhibitors, and they're really ahead of us. We'll get there, but we're not there yet.
Right.
Can you explain a bit more about MRD and how that can be used to guide treatment?
So MRD, some people say minimal, some people say measurable residual disease. Both terms I think are acceptable, but basically what it's looking at is when you can't see any CLL cells under the microscope, you can still detect them through various very sensitive techniques like flow cytometry or sequencing. Right now I see MRD mostly as a prognostic test, meaning at the end of the year of Venn Oben, you can check MRD, and that will really be helpful in predicting how long the remission is likely to last. I don't see it yet as a way to decide on the length of therapy. We have trials looking at this question now. For example, if you're still detectable for MRD at the end of that year of Venn Oben, can you do a second year of venetoclax? Is that helpful? We don't know yet. So I don't guide therapy duration, but it is helpful for prognosis.
Great, thank you. And then here's a loaded one. What's your favorite BTK and why?
Nikki?
I do not have a favorite. It was ibrutinib. Obviously, it's not anymore. I think we're using zanubrutinib more and more. I see us continuing to move in that direction more and more.
Yeah, I mean, I think it's great to have options. I would say, some of the nuances here, like if I have a patient who's struggled with migraine headaches over the years and I'm choosing between Acala and Xanu, I'll probably choose Xanu for that patient because we know Acala has a higher risk of headache. On the other hand, in the head-to-head study that Amy showed, zanubrutinib did not seem to have a lower risk of hypertension compared to ibrutinib. So if I have a patient who's struggling with hypertension, I'll start with acalabrutinib. So you can use some of these nuances to choose, but the good news is that they're both great drugs, so you really can't go wrong.
And we have choices.
Yes.
That's incredible.
Yeah. I'm going to combine two questions. So can you elaborate on disease eradication? And dovetailed with that, what do you consider a functional cure?
These are complex questions. Disease eradication is maybe a little bit of a misnomer because to me it sort of implies that the disease is completely gone. But really what it means is just kind of killing off as many cells as possible in my mind. Functional cure, I think you start to really have to get into the decades of remission category. So that's why with FCR, when we saw people still in remission 10 years after their 6 months of FCR, we started saying, okay, maybe that's functional cure. We're certainly not there yet with these targeted therapies. Only 6 years of follow-up with Venn Oben, so I think we just need more data.
Somebody wants to know which antiviral we usually use. For me, it's insurance-driven. Yeah. We use acyclovir or valacyclovir, whatever the patient's insurance plan prefers. That tends to drive a lot of things. And then someone asks, is venetoclax well tolerated following BTK inhibitors?
I certainly think it is. People, regardless of what line of therapy, people, once they get through those first few weeks with all the monitoring, venetoclax tends to be a pretty easy drug. You do see the neutropenia popping up. You see some gastrointestinal side effects, but they're usually pretty manageable. Okay,
so we are 38 seconds over, and I have a message here that the 2 pharmacoeconomic references are on the website. So look at the website, and you can get to those references. That was a great question because that's very interesting data. And if there are no more questions, thank you so much for joining us here this evening, and I hope you had a great conference.